focus seems to be on addiction. We have an addiction crisis. These opioid users are addicts. Dr. Phil says 80% of heroin addicts started on pain pills. Give me a general sense of whether you feel that the focus of public attention is on the right spot.
Well, it's not. I mean, when we talk about opioid abuse, we need to clarify which opioids we're speaking of. But also, if we want to improve pain management, we also have to mention what we're going to do about that as well. As far as Dr. Phil is concerned, if he claims to have a study that indicates these alarming statistics, the first thing as a scientist that I always ask for is, let me see the study itself. Is that there is some data to show that an extremely small percentage of individuals who started misusing prescription drugs have progressed on to heroin. But number one, it's an extremely small group. Number two, there are other things clearly going on about why someone was misusing prescription drugs in the first place. And then finally, we also have to make a clear distinction between causality and association. Think about a fire engine in a fire. Is that the bigger the fire, the more fire engines. Well, fire engines do not cause the fire. They are merely associated with the larger fire. These things are quite complex and are not and should not be discussed in terms of as if they were to appear on a bumper sticker.
It might be that 80% of heroin addicts took pain medication at some point, but it's a pretty good chance, isn't it? They also smoked marijuana, they had cocaine, they drank as kids. It's not causality.
Absolutely. There was this one article, an interesting article the other day I read about how this individual, when he was early in his 20s, had a surgical procedure, ended up with prescription drugs, and then started to abuse them. Of course, there's a distinction between misuse and abuse and measuring that. But upon further exploration, this same individual was also involved in taking illicit substances from a very early age. So it's not this narrative that we continue to hear about. I mean, opioids can be beneficial, prescription opioids that are prescribed appropriately. But just like with anything else, if misused or abused, could lead to trouble.
The idea of addiction versus dependence. Dependence does develop for these chronic pain patients. They are dependent on their medicine the same way sort of a diabetic would be dependent on insulin.
Yes. Dependence is not addiction. Those terms are sometimes used interchangeably, and that would be incorrect. And as you noted, is that a person can be dependent on insulin because they need it to be able to function. It doesn't mean they're addicted to it. Addiction is a complex biopsychosocial phenomenon characterized by compulsive use despite harm.
I've heard some people say it's not an opioid addiction, it's an addiction of despair, looking at socioeconomic factors, depressed economies, things of that sort.
Well, Das Gupta and his colleagues recently released a commentary that there was essentially no easy fix to the so-called opioid crisis, because we know that certainly drugs are a part of the problem, but we have to look at the bigger picture and the particular details about how we got into this. Is that what other factors are going on? Why are people misusing those drugs? Why are they abusing their drugs? Are they self-medicating for other mental health issues? If they are, do they not have access to mental health services, etc.?
What role did the pill mill era play in what we're seeing right now? The explosion, the drug companies come out with these miracle drugs, they seem to work, doctors prescribe them, pharmacies go way over the top in making them available. There are policymakers who think that's what we're reaping right now.
Well, of course, there are no simple explanations. Now, when we talk about a pill mill, that of course is a pejorative term. It is a medical practice that is not consistent with good medical care. If you have a medical practice that operates also as a bait shop, that kind of tells me something that's not a legitimate practice. You have a particular clinic that does not perform any physical exams, takes requests about what type of drugs they want, etc., trades sex for drugs. These are what we would characterize as pill mills, and this is not legitimate medical practice. So the thing is, if we look back 20 years ago, we're kind of where we are back then, but in worst case scenario, is that we had an undertreated pain situation. And in response was kind of a simple response, well, let's just prescribe more drugs. As we saw, that may not have been always the best case reaction to every single case. And now we do have a pill problem, but we have many other problems as well. We have illicit substances that are driving this overdose problem. And so to merely pass it off as merely a pill problem because of greedy companies wanting to take advantage of an increasing market share, it's not that simple.
Used to be somebody dies of heroin, we called it a heroin overdose. Now it's an opioid overdose. It's all kind of lumped together. Almost seems like it's on purpose.
Well, the devil is truly in the details. And when we start lumping all opioids together, that is problematic on a variety of levels. Because when we talk about opioids, are we talking about prescription opioids, or are we talking about illicit opioids such as heroin? Heroin cannot be prescribed in the United States, but it is being conflated with all other opioids to unfortunately perhaps boost the statistics. This creates a certain amount of hysteria and alarm to get us to pay attention, because we're struggling in the United States with a lot of shiny objects, and we have to have a lot of distractions. But what's important is we drill down to seeing what the determinants are, what is contributing to this problem, and instead of using these broad assertions as far as opioids are concerned.
You wrote a paper with Dr. Shatman since we last sat down and spoke that took to task the CDC. And I don't want to put words into your mouth, but it seems like what the CDC's opioid group did was not only wrong and misleading, but deceptive, almost on purpose. I mean, they went to great steps to achieve the end that they achieved.
Well, as we point out in the paper, I think that really the CDC missed an opportunity here. And I'm going to contrast what they did with some legislation that followed. The Comprehensive Abuse and Recovery Act of 2016 actually called for the creation of a pain management task force in which a variety of stakeholders were at the table. That's preferred. That's what we want, so that everybody can be heard. But as we pointed out in the article, as well as there are many articles, other articles which exist out there, is that the CDC did not have such an open presence, so to speak, of gaining information from other sources. And one example certainly was that their draft of the CDC prescribing guideline did not appear on their website. The only way that you could actually view it is during a webinar, and people had trouble accessing the webinar. And then once they were in the webinar, they had about 25 hours to be able to respond to that brief version of what they had seen. That is not good public input or the input of professionals. And so I think the CDC had a good idea of helping to create these guidelines, but unfortunately the people that they had staffed in the work group, etc., limited the number of seats available at the table.
Your paper punched them right in the gut. Did they respond?
Not to this day. The CDC is really a political agency because they're politically created, so to speak, in the government. So it was no surprise that they decided not to respond to it.
I mean, they've said, oh, this is just voluntary. We didn't mean it to be imposed. They had to know how this was going to play out.
It certainly was foreseeable that a lot of states, through their state medical boards or their legislatures, would seemingly just adopt the CDC guidelines without questioning them, without going into the details about the problems associated with their creation. And so the so-called idea of voluntary guidelines was kind of disingenuous because it was foreseeable what ultimately could happen. Now, the thing about unintended consequences are, of which we've seen many as a result of the CDC guidelines, is that the CDC should be and actually implement changes, revisions, clarifications of which there's been limited results.
Is that going to happen?
I do not foresee it.
You know, here in Nevada, like other states, there's been a crackdown on chronic pain patients, on pain management, on legitimate prescriptions. How would you anticipate that will affect addiction rates, overdose rates, things of that sort?
Well, the problems associated with curtailing prescription drugs is that prescription drugs, of course, should be regulated for a variety of reasons. There are good public health concerns for that. But to arbitrarily deny prescription pain medication to those folks that need it, to reduce dosage without regard to their individual condition and function is problematic, because when people are experiencing pain, if they cannot get the relief legitimately through their prescriber, what do you think is going to happen? They're going to end up self-medicating. And the problem with self-medication is they're going to be using perhaps illicit substances such as heroin, or they're going to be using licit substances such as alcohol. And mixing alcohol and prescription drugs can be fatal.
Well, you've seen it across the country. You and Dr. Chapman have written about it. The results are pretty clear in states, for example, where fentanyl, illicit fentanyl, has become rampant. You cut down on legitimate pain patients and prescribe medicine, the ODs go up.
People will find some way to manage their pain. And what we want is effective and safe strategies to do that that are covered by insurance and are in assistance with their physician. But when they self-medicate, no one is supervising that, and that is clearly going to be harmful. We've not only seen problems associated with self-medication, but we've also seen problems associated with non-opioid drugs, such as the over-the-counter use of non-steroidal anti-inflammatory drugs. 16 to 20,000 people die every year from those type of drugs due to GI bleeds and a variety of other factors. The thing is, whether we're dealing with NSAIDs or we're dealing with prescription opioids, what is appropriate for that patient in that particular condition? So not only people are unfortunately medicating to make up for this gap, but some people are actually taking their lives.
A lot of them. If you wanted to drive pain patients to use heroin, if you wanted to drive people to go to the cartel and avail themselves of those services and products, seems like the strategy would look a lot like this.
Well, the policies that are coming out recently are not balanced. And because what we want are balanced policies, those that ensure appropriate access while at the same time prevent abuse. If we only look at one side of the equation, the abuse side, we're neglecting the legitimate treatment of pain on the other. And what is going to happen if we do not address that? There's going to be additional harms. So whenever a policymaker mentions about wanting to reduce inappropriate access, reduce harm, that's fine. But also, what are they going to do about the legitimate treatment of pain? And unless they address that as well, then that particular policy is not balanced.
The pain doesn't go away. And you hear the stories. These people are desperate. I mean, they don't go a day without the medication that affects their lives.
There are some people that have injuries that it takes them 30 minutes to even get out of bed. What's going to happen if they don't have any type of access to that type of material, those type of legitimate products to enable them to do that, to get out of bed, to be able to function, to have relationships, to be able to work at their job? Is that this Just Say No program should not be what we place all of our eggs in one basket with.
Just Say No hasn't exactly worked out well with any drug, has it?
Scientifically, no. Ideologically, politically, perhaps yes. We want proof in the pudding. Unfortunately, the government oftentimes does not evaluate its own policies to see if they have been effective, how they can be improved, or perhaps how they have resulted in unintended consequences.
Yeah.
So that's a big drive, and it's important for the government to realize that, because we essentially are the government.
I mean, the war on drugs has been underway for 50 years. Is there any drug that you can't walk out 10 minutes from here and buy, if you wanted it?
Well, the war on drugs has been a very long campaign. It is a war on our own people, and unfortunately, the successes have come at significant costs.
Here in Nevada, the new law kicked in January 1st, so we're seeing doctors suddenly realize, oh my gosh, I better pay attention to this. This is affecting me and my patients, and they're pushing back a little bit, a little, too late maybe. We hear from lawmakers, hey, we had these hearings. Where were you guys? There was no input from chronic pain patients. Doctors, pain management doctors didn't come up here. How would you explain the lack of involvement by pain patients and doctors in that process?
Well, there perhaps could be a variety of factors going on. Number one is that perhaps some healthcare professionals realize that, will anybody actually listen to what I have to say? Secondly is to be able to drive down to wherever these hearings are is considerable personal and business expense as well, canceling appointments, and procedures. And third is that what is this idea about notice? Is that notice is essential in the law, but if you publish about a hearing, is that something in which your potential audience, physicians, for example, are going to be aware of? Now, of course, your state medical associations, that's what they're in the job for, is to be aware of those type of things and to notify those practitioners. And they certainly should have been there as a result.
I would think, you know, was so much stigma attached to it that doctors wouldn't want to stand up and speak out because they're worried about being labeled as pro-drugs.
Well, that is a potential, is that for those people that are standing up for the use of prescription opioids and pain treatment could be attacked. We know that there are individuals on the extreme that are attacking anyone that is associated with the pharmaceutical industry, and in whatever capacity. And this is not helpful. And so a lot of times when these particular extremists are attacking people that support the use of opioids in the treatment of pain, sometimes I'm afraid that it's more about them than actually the patients that they're trying to protect. And so these extremists, what they need to do to help all of us is come up with real solutions to not only help prevent abuse, but also to ensure appropriate treatment of pain.
Since we've aired our stories, we've heard from thousands of pain patients who are at least making signs or indications that they're trying to mobilize and get together and pull together and maybe start speaking out. But I can understand why they wouldn't show up at Carson City, 400 miles from here. It's hard enough for them to get up and go to the kitchen, let alone to go to the state capitol.
Well, it's kind of this idea of mobilization, is that who is the particular audience? I mean, you have folks that, like you say, are trying to make it day by day. They've had their jobs affected as a result of the physical pain. And so they're not going to be able to get up and simply drive to wherever this hearing is and be able to testify. You know, some of them perhaps can write letters, some of them can make calls, some of them can even go to the website of Indivisible, which actually was created in response to the current national political debate, but Indivisible has a guide in which can help people access the political process. But it is a challenge for those people.
Is there something you could say that gives them some kind of hope? I mean, is there a way forward for them? Any ray of hope that somebody comes to their senses and helps out the legitimate pain patients?
Well, right now it is kind of an uphill battle for them. Is that, number one, anybody sick from whatever condition, the most that they want is to be better. And people suffering in pain want to have their pain relieved. They want to be able to engage in social activities. They want their function improved. And so what's the likelihood that will happen in the current crisis? Well, what we want is, if prescription opioids are appropriate for a person, then they should have them. If they are not, then they should not. If there are other alternative treatments that are as effective and safe and covered by insurance, that's what should be done. Now, in this current state of affairs and the hysteria associated with it, is that you do need to reach out to your legislators, you do need to reach out to your elected officials in a variety of ways, and you do need to make your stories known. But at the same time, there are additional things that perhaps people will be soon thinking about, such as through litigation. And that is that seeking access through the courts for their particular relief. That might mean suing healthcare providers for abandoning their patients, or engaging in perhaps medical treatments that are not appropriate for their particular condition. It could also result in perhaps even injunctions to stop a law from taking effect because of its impact it can have on citizens, and a variety of perhaps different legal theories could result.
Yeah, being denied care for a legitimate medical issue, it seems like you'd have some kind of legal standing.
Well, the interesting thing is that years ago, with the physician-assisted suicide cases that went before the United States Supreme Court, the justices noted that, and merely commented in what, as a lawyer, we would call dicta, is not something directly argued in front of them, but they did comment in aside, saying that, you know, if a state were to create barriers to palliative care, then we might have a different issue before us. And when we talk about palliative care, we're talking about comfort care. And palliative care is not, it is oftentimes associated with end-of-life care, but really it is also supposed to be associated with those facing chronic life challenging illnesses as well. So it need not be terminally ill patients. And so these state-created barriers to palliative care, saying no to drugs but not providing any other effective alternatives, could raise a variety of constitutional concerns.
Insurance companies, of course, are happy to not pay for anything they can get away without paying for, and opioids now are on the list. They don't pay for alternative treatments. They don't want to pay for this either. And they've been slicing it, at least here in Nevada, in that we will cover your opioids up to a degree, but only if it's for cancer, as if cancer pain and non-cancer pain, cancer pain is somehow more noble than non-cancer pain. There is other kind of pain that is just or more painful than cancer pain, right?
Well, there are significant painful issues associated with cancer and non-cancer conditions. And it's problematic to separate out cancer. Not that it need not be, but to realize is that significant pain could be incurred in other conditions. And you still have a potential problem with what we call pharmaceutical diversion when dealing with end-of-life care, is because if a person in hospice, for example, passes away, you've got a lot of leftover medication, which is also the potential for misuse or abuse, which are two separate terms. And so it's something that we always have to consider, and in fact, in one particular state, is that for a Medicaid population, the state requires that even patients on palliative care, end of life, cancer, who are being treated for cancer, still have to have their medication approved through pre-authorization. And so one day I called that number to see how long it would take to get that authorization, and after 30 minutes I hung up the phone because no one answered. That's denial of access, ultimately denial of care and treatment.
Sounds like eventually a lawyer or a law firm will get involved in this.
It is. It's unfortunate that we have to wait to the death of an individual or a particular injury to an individual before we actually do something. We want our government to be responsive. We want our government to be balanced. Right now, things are out of balance.
It's it's not as much an opioid epidemic as is epidemic of fear. These chronic pain patients, millions of them, are afraid. They're afraid every time they go to the doctor. Is this the day I get cut off? They're afraid every time they go to the pharmacy. They're hurting.
Well, one of the concerns is that what we don't want is leftover medication that's not needed. If you have a particular acute pain condition and you're prescribed, let's say, 30 days worth of pills, and after the third day you do not need those pills anymore. Well, to have them left over in your house is problematic on a variety of levels. It could result in misuse, even if it's a physical condition. So they could also be susceptible to theft during burglaries, etc. So we don't want that leftover medication. That creates micro and macro health concerns. But the challenge, though, is that if people are being denied medication, being denied access to pain medication in particular, they're less likely to return that pain medication during take-back days because they're afraid they may not be able to have it when they actually need it.
Just seems like somebody who chooses or has an addiction and wants to shoot heroin somewhere else, their problem should not be a reason that somebody with cancer or some other kind of pain here should be denied medication that works for them.
Right. I mean, here we're talking about the abuse and misuse in the broad picture. The big picture is the majority of people are doing fine. But at the same time, we have a small segment of the population, and we're having a significant rise in deaths due to illicit substances that is driving this problem. So that needs to be a concern and needs certainly to be addressed as well.
I mean, 80%, something like 80 or 90%, and was it Massachusetts, New Hampshire, the O deaths?
Right. A recent study by the Department of Health in Massachusetts found that only 8.3% of the deaths associated with overdose, those individuals had a prescription. So the overwhelming amount of overdoses were from illicit substances, and that's something that needs to be focused upon instead of trying to fight it in a different way. Look for a different example, in a different context. is the overprescribing of antibiotics. We have a problem in the United States concerning the overprescription of antibiotics. And it creates a micro-health problem as well, because you're getting antibiotics for something that antibiotics will not address, so that harms you. You build up resistance. And it becomes a macro-health concern for our society. But what do? Do we start denying people access to antibiotics that it's necessary for them to have because of the greater good? That's problematic.
One last question. Back to the idea of addiction and dependence. An opioid patient in pain management jumps through all the hoops, pees in the bottle, count their pills, do whatever the doctor requires. They could still be dependent on the medication. I mean, just and could actually suffer withdrawals. I guess the question is, so what? I mean, if it works for them, if they've reached a stable level, and they can function as human beings, so what?
Dependence is not addiction. Withdrawal is not addiction. Addiction is a completely separate matter. A lot of people can be managed well on opioid therapy, prescription opioid therapy. It's not for everybody. Some cannot. But for those that are managed well, why are you trying to change their treatment? If it's going to be a better treatment, that's fine. But if you're going to cause harm as a result, that's not consistent with the goals of medicine.
Okay. Anything else?